Hello, and welcome back to another lecture video. My name is Carlos Brian Francia, and today we will be talking about hormones. So we will be talking about the endocrine system. For hormones to circulate around the body, we have to do three pathways. And this first pathway is for hormones that are lipid soluble. That means that they can mix with the lipids and pass through the phospholipid bilayer. So this outside right here, this little membrane, has lipids that act as a gate for this cell. And so some hormones can cross through this gate and go into the nucleus. So when I'm thinking about lipid soluble hormones, I'm thinking about testosterone. We're just going to call it testosterone test to save on time from writing. So testosterone. We also have estrogen. Because sex hormones, as they call it, testosterone, estrogen, progesterone, these are derived from cholesterol, and cholesterol is a lipid. Another exception for the lipid-soluble hormones would have to be your thyroid hormones. And some of the best known thyroid hormones are T3 and T4. And we're going to talk about these guys later. But thyroid hormones right here are actually amines, and these guys are lipid soluble. Normally, amines are hydrophilic, so they cannot be mixed with lipids, they cannot be mixed with fats, they have to go into the fluid portion of the cell. That's typical for amines, but thyroid hormones, which are amines, are the exception to this rule. So how does a lipid-soluble hormone create proteins? Hello, and welcome back to another lecture video. My name is Carlos Brian Francia, and today we will be talking about hormones. So we will be talking about the endocrine system. For hormones to circulate around the body, we have to do three pathways. And this first pathway is for hormones that are lipid soluble. That means that they can mix with the lipids and pass through the phospholipid bilayer. So this outside right here, this little membrane, has lipids that act as a gate for this cell. And so some hormones can cross through this gate and go into the nucleus. So when I'm thinking about lipid soluble hormones, I'm thinking about testosterone. We're just going to call it testosterone test to save on time from writing. So testosterone. We also have estrogen. Because sex hormones, as they call it, testosterone, estrogen, progesterone, these are derived from cholesterol, and cholesterol is a lipid. Another exception for the lipid-soluble hormones would have to be your thyroid hormones. And some of the best known thyroid hormones are T3 and T4. And we're going to talk about these guys later. But thyroid hormones right here are actually amines, and these guys are lipid soluble. Normally, amines are hydrophilic, so they cannot be mixed with lipids, they cannot be mixed with fats, they have to go into the fluid portion of the cell. That's typical for amines, but thyroid hormones, which are amines, are the exception to this rule. So how does a lipid-soluble hormone create proteins? The next two pathways are what we use when we have water-soluble or hydrophilic hormones. A good example of this is adrenaline and noradrenaline. When we have adrenaline, and let's use the scientific name, when we have epinephrine, and norepinephrine, we'll talk about these in detail later. These guys right here are catecholamines, And if I misspell something, I don't care. And catecholamines are amine-based. Thyroid hormones are also amine-based, but notice that thyroid hormones are the exception in which they are lipid-soluble. If I repeat something, it's very important. It's always tested on exams. So for these guys, which are amines, they are water-soluble. Let's say that when we have a person who's having an allergic reaction, let's say a kid ate some shrimp and they didn't know that this soup had shrimp, and their airways are closing and they're suffocating, we inject epinephrine from the EpiPen. When we inject the epinephrine goes into the capillaries. So we have this little triangle, and the epinephrine goes into the extracellular fluid, and it attaches itself into a protein membrane. So it's kind of like pressing this button on the elevator. When the epinephrine presses the button on the elevator, it sends a signal. So the first signal goes to a G protein, and this G protein goes to another little membrane called adenyl cyclase. So all this G protein is doing is that it's sending a signal to another protein. And cyclase, ACE means enzyme. ACE is an enzyme. So what is this enzyme going to do? It's going to make something circular or cyclical. What we do is that we convert adenosine triphosphate, so adenosine with 3 phosphates, and we're going to convert it into cyclical adenosine monophosphate. Now this is pretty important because CAMP, as I'm going to call it, CAMP is a secondary messenger. What is a secondary messenger? When we use these hormones, we have one little hormone, but this hormone is going to start making a cascade. So we start with one hormone, we make, let's pick a random number, 100 CAMPs. And the 100 CAMPs start making activated proteins. Let's say each CAMP makes 10 activated proteins. Eventually we're going to have more than a million proteins. And each activated protein does something different. So we start with one signal and we end up with a million signal in less than 5 seconds because everything happens in a snap. When you inject this EpiPen into a person, you don't wait 10 minutes and then you see that person improve. You inject it and within 30 seconds this person's airways opens up because epinephrine uses this cascade to do that process. And so first epinephrine attaches itself to the elevator button, which is just a membrane receptor. The receptor sends a signal to the G protein. G means go, so this protein is going to go activate adenyl cyclase. Adenyl cyclase is going to convert adenosine triphosphate into cyclical adenosine monophosphate, since cyclase makes something cyclical. It also gets rid of 2 phosphate ions, so you could just say that, inorganic phosphate just floating around. And these little CAMP molecules each will activate a protein kinase. So we started with one signal, now we have, let's say, 10 or 100 CAMPs, and each CAMP activates a protein, so now you have more than a million proteins that are activated. So it's a cascade, it's an amplification of a signal. But how do we stop this cascade? How do we stop this signal? Well, inside the cytoplasm is something that will eliminate or deactivate the proteins. And this is called phosphodiesterase. So we're going to write this, we're going to write we're going to put esterase. Why did I highlight di? Well, this cascade will die when this enzyme, ASE means enzyme, when this enzyme quote unquote kills or deactivates the protein. So this activated protein kinase will activate proteins, and to stop this cascade, phosphodiesterase, which is just wandering around the cytoplasm, let's say it's right here, just when it comes in contact with this guy, it's going to shut it down and the cascade ends. So that is the end of that cyclical adenosine monophosphate cascade. So within this cascade, you have the secondary messenger cyclical adenosine monophosphate, which is the secondary messenger. Here we have the other pathway for water-soluble hormones. So again, this is for the water-soluble hormones or hydrophilic hormones. Instead of using cyclical adenosine monophosphate, we will use inositol triphosphate. So the IP3 is going to be the secondary messenger. Let's use another hormone as an example. Let's use calmodulin. So calmodulin is going to change the amount of calcium within the body, and it's going to act upon this receptor. So calmodulin acts upon this receptor. It's pressing the elevator button, and this receptor activates a G protein. So this G protein is going to go and do a cascade. Instead of activating adenyl cyclase, I don't know how to pronounce it, but instead of activating this guy, instead we activate phospholipase C. So PLC, phospholipase C. Again, ACE means that it is an enzyme, and what this enzyme does is that it gets a phospholipid, and it's going to snap it in half. So let's say you have a stick. You're going to break this stick into two pieces. One of these pieces is called diacylglycerol. And the other piece is our secondary messenger, and this is called inositol triphosphate. For diacylglycerol, we just leave it behind. It's kind of like eating a Twix bar. One of the Twix bars are for you, and the other one is for your friend. You just have the diacylglycerol hanging around somewhere else. What we want to focus is on the inositol triphosphate. For the inositol triphosphate, it will go and it will bind to another channel. So when this channel binds to the inositol triphosphate, it's like pressing another elevator button. When you press this button, the gate opens. This gate is connected to the endoplasmic reticulum. And in this case, the endoplasmic reticulum has calcium. Now calcium flows from the endoplasmic reticulum and it goes into the cytosol. And now this calcium is going to be used by various proteins, and these proteins will be activated. So here we only have one hormone, It presses a G protein, and now you have some IP3. So you may have, let's say, 10 IP3s. So each IP3 opens up a channel, and you have thousands and thousands of calcium. So let's say that now you have a million calcium ions. And each calcium ion can activate 10 proteins or whatever, so you may have 10 million proteins. So just from one hormone, we have the activation of 10 million proteins. And that could be an even larger number. I'm just making up numbers so that you can understand that this cascade can allow us to create a large signal from just a little small press of a button. So to recap, the calmodulin clicks on the membrane receptor, it activates the G protein activates the phospholipase C. Phospholipase C breaks down a phospholipid. We have diacylglycerol, that's left behind, we don't care about it. And it also creates inositol triphosphate. Inositol triphosphate is the secondary messenger that's actually going to be carrying the signal. It goes into this calcium-gated channel, and when the calcium binds to this channel, it opens up on the endoplasmic reticulum, and thus a large amount of calcium can flow into the cytosol and start activating proteins. We will now be talking about the master control center of the brain, for hormones at least, and that is called the pituitary gland. So this is the pituitary gland. So we're going to be very familiar with this guy within the next 30 minutes. So it may be small, but he does have very big plans for your body. The pituitary gland is inferior, that means below, so it is inferior, below the hypothalamus, and it communicates with the hypothalamus. So the hypothalamus will send signals to be transmitted into the pituitary gland, and it releases hormones. The pituitary gland is separated into the anterior, that means the front, and it's also separated into the posterior pituitary gland. We will first be discussing the posterior pituitary because it's a bit more simple to remember than the anterior pituitary. The posterior pituitary only releases two hormones, and they're called oxytocin and antidiuretic hormone. And the way it does this is that within this hypothalamus, you have these signals. So these signals travel down this information highway, which we call the hypophyseal tract. So the hypothalamus uses this information highway to signal the posterior pituitary to release these hormones. These information highways is called the hypophyseal tract. So this right here is the hypophyseal tract. And since it's between the pituitary gland and the hypothalamus, we just combine the words, hypothalamo-hypophyseal tract. This little bridge that you have here, that's called the pituitary stem, or the stalk. And this is called the infundibulum. Once the signal goes into the posterior pituitary gland, the posterior pituitary gland has to secrete or release these hormones. And the way that these hormones are pushed into the systemic circulation, which is like the major arteries and veins of the body. So let's say we got to get this hormone, oxytocin, to the uterus of a woman. How does that hormone leave the posterior pituitary gland? It is released via the capillary plexus. So here, plexus just means a collection. So capillary collection, it is a collection of capillaries that circulate in the posterior pituitary. If you didn't have these capillaries, the gland would not have oxygen, it would not have nutrients, it would die. You would have a dead tissue right there. So the capillary plexus supplies the posterior pituitary with oxygen and nutrients, and it also allows oxytocin and antidiuretic hormone to circulate into the rest of the body. Also, before I forget, I want to mention that the posterior pituitary, for the posterior, does not make the hormones. Doesn't make hormones. Instead, it just kind of acts like a grocery store in which the groceries, which are the hormones, are placed inside the posterior pituitary, and the signal just releases the groceries from the posterior pituitary. So that's always on exams. The posterior pituitary does not make hormones, it just secretes them. The anterior pituitary creates the hormones, and it also releases the hormones. Within the hypothalamus, we have two collections of neurons. First, we have the paraventricular nucleus, and we also have the supraoptic nucleus. So the little complication that you have when learning about the posterior pituitary are the nuclei. And that's when we have to kind of finesse the way we learn. So I'm going to be talking about oxytocin first. And for me, it's easier to remember that oxytocin is secreted by the paraventricular nucleus, or it's signaled by the paraventricular nucleus when we think of a couple arguing. So this young man right here, who looks like Tarantino, he just found out that his wife is pregnant. I don't know how you would just barely find out now. She's clearly showing. But he is actually paralyzed with fear. So he is paralyzed with fear. Paralyzed. And now he has to find a way to get out of this relationship. He has to be tricking her, paraventricking her out of this relationship. So he says, I have to go put air in the tires and get milk and buy some cigarettes. I'll be right back. And then he never shows up again because he was paralyzed with fear. But why do I relate this with women? Well, I relate oxytocin with women because when the woman is pregnant, the levels of oxytocin, we're just going to call this oxy, the levels of oxytocin in a pregnant woman are decreased. But when she's about to have her baby and she undergoes labor contractions, that's when the uterine walls start contracting and pressing, then the levels of oxytocin are going to be increasing because oxytocin causes contractions. It causes contractions. And it actually undergoes a positive feedback loop. So we're just going to call this a feedback loop. What do I mean by that? When a woman undergoes contractions, her brain releases oxytocin. Really, the posterior pituitary gland releases oxytocin. The uterine walls contract. And when that happens, the muscles in the uterus will send a signal to the brain to send for more oxytocin. So now you have the cycle. You have the oxy going into the uterus, and the uterus contracts, and when it contracts, it sends more signals to the brain to release more oxytocin, and thus the signal continues until the baby exits the vaginal canal, and that is called a positive feedback loop. When a woman is pregnant, normally the oxytocin levels are decreased, but when she's having contractions, the oxytocin level increases until the baby is delivered. Oxytocin is also responsible for milk letdown. What is milk letdown? Well, when a woman is breastfeeding her child, the baby suckles on the nipples, and within the nipples are little muscles, and when these muscles are pulled on or contracted, the production of oxytocin will increase during breastfeeding. So when the baby is suckling, the nipples are contracted, and again it undergoes a positive feedback loop. So the oxytocin causes nipple contraction, so this is contractions again. When the nipples contract, they signal the brain to produce more oxytocin, and that allows the milk to be squirted out of the mammary glands into the baby's mouth. And also, oxytocin is known as the cuddle hormone or love hormone. Love hormone. So let's do that. So when the mother is breastfeeding her child, oxytocin is being produced, and now she feels an even stronger connection to the baby. The next hormone in the posterior pituitary gland is called the anti-diuretic hormone, and that's going to help preserve water into the body. And it is released by a collection of neurons called the supraoptic nucleus. And again, nucleus just means a collection of neurons inside the central nervous system. But how do we remember this? Well, when I was younger, I would always watch Ice Age. And there was a character who I really relate to, and his name is Scrat. So here is Scrat. And Scrat was always trying to get that acorn. He always wanted to have dinner, but for some reason he never got the acorn until pretty recently. But he found out that they're selling a new product called acorn water. So here's acorn water. And Scrat loves acorn water. But notice how the acorn water is above, it is supra, meaning above, his eyes. So he has to look upwards towards the acorn water. So this water is supraoptic. So this is the supra, meaning above, and then optic, meaning his eyes. So it is above his eyes. Scrat is looking at the acorn water, supraoptic, and this is anti-diuretic. diuretic hormone. He loves acorns. But when does the body release antidiuretic hormone? The body releases antidiuretic hormone when the hypothalamus, using osmo receptors, so this is a osmo receptor, it senses that the amount of solutes in the blood is too high. It also senses when the blood pressure is too low and the blood volume is also low, or when the flow of blood is too low. But to talk about this, we have to get into osmolarity. When we talk about osmolarity, we're talking about the amount of solutes within the blood. So a solute can be minerals, it can be salt. So let's say that we have a person that just ate a bunch of barbecue, and barbecue is very salty and it has a bunch of sodium. So the concentration of sodium within this artery, which is incoming into the kidney, is high. The way the kidney operates is that it will take the blood and it's going to take away the wastes, it will take away some minerals, and it's going to take away some water from the blood and filter the blood and then pass it into the systemic circulation. When there is a high concentration of solutes inside this artery, the water from the surrounding tissue will be pulled into the artery. So now we have a collection of more and more water between these sodium ions. So now this artery is swelled up with water, and this increases the blood pressure. So that's why whenever you have a person or a patient that says, hey, my ankles are swollen, I just ate 10 pounds of barbecue brisket with barbecue sauce and I ate some salt on the side, now my blood pressure is high. This is why. You have a large collection of sodium inside this artery or inside the blood, and it pulls the water from the surrounding tissue into this artery. And now the blood pressure increases. And now the kidney, when it filters the blood, it removes some of the ions, some of the sodium via urine, but it also releases a lot of water via the urine. So over time, the blood pressure naturally goes downwards, hopefully, if there's no impairments. But also, the amount of water inside the blood is decreasing, and so the volume of the blood is also decreasing. So the blood volume is decreasing because this water is being excreted by the body. And so the antidiuretic hormone, which is a peptide hormone, by the way, peptide, and so is oxytocin. When the body says, hey, we don't have enough blood pressure or we're losing too much water, we got to stop excreting water, what do? We release antidiuretic hormone from the posterior pituitary gland. But how does this work? Inside the kidney, when it filters the blood, the water portion of the blood, and also the solutes, will travel along this long neck inside the kidneys, and this is called a collecting duct. So normally the collecting duct is pretty solid and the water is filtered out and the solutes are excreted. So we have a large volume loss. The way antidiuretic hormone works is that antidiuretic hormone is going to increase the amount of holes inside the collecting duct. These holes are actually called aqua, which is water, porins. And of course, pore is like a little hole. So antidiuretic hormone increases the amount of aquaporins inside the collecting duct within the kidneys. And so now water can excrete from the collecting duct. We can pull some water and pull it into the tissue. So now water is free inside the tissue. And what this does is that it concentrates the amount of solutes within the urine. So instead of having clear urine, which is a lot of water being excreted from the body, we now have very yellow urine, almost like a dark color, because there is a large concentration of solutes being excreted. The water is being preserved inside the body. This water eventually will make its way into the blood and it will increase the blood volume. It's also going to increase the blood pressure, and it's going to increase the blood flow. So the speed at which the blood flows. So to recap, within the posterior pituitary gland, we have the oxytocin, we have oxytocin, and we also have antidiuretic hormone, which is also called vasopressin. So vascular pressing, which increases the blood pressure. And both of these guys right here are peptides. But now we got to talk about the anterior pituitary gland. So here we have the anterior pituitary gland, and the way it operates is a lot different from the posterior pituitary gland. Within the anterior, so we have the anterior pituitary, we have veins. So notice that for the posterior pituitary gland, you were using the hypothalamo-hypophyseal tract, but instead we're using veins. So it uses veins and not tracts. This system of veins is called the hypophyseal portal system. So this is the hypophyseal portal system. And what it does is that it allows these hormones to be circulated into the anterior pituitary gland without leaving this area. So we don't want these hormones to be circulating around the legs or the thighs and then going back up to the anterior pituitary gland. Instead, we want to have our little separated circulatory system, and it makes the communication between the anterior pituitary gland and the hypothalamus a lot shorter. And this, if you want to be nitpicky, the superior hypophyseal artery is derived from the carotid artery, if you want to be a brainiac or something. Anyways, so this first collection of capillaries is called the primary capillary plexus. And we also have another collection of capillaries. And again, this is called the secondary capillary plexus. And when the hormones are being secreted by the anterior pituitary gland, it exits from this little vein that we have here, and it goes into the systemic system. So it go to like the muscles or to the fingers or whatever you need it to go to. Also, the anterior pituitary gland creates and it also secretes hormones. But how does it know when to create the hormones, and how does it know when to secrete the hormones? Well, it gets it receives hormones from the hypothalamus. So a great example of this would have to be when the anterior pituitary gland has human growth hormone, but in order to get human growth hormone, the hypothalamus has to release another hormone called human growth releasing hormone. So human growth releasing hormone travels down this little nerve, and it goes into the little capillaries and it diffuses, and now the anterior pituitary gland will secrete and create human growth hormone, and that little human growth hormone is going to go into the systemic circulation. So you need hormones that are releasing to go into the anterior pituitary gland and stimulate the gland to release the hormones. So human growth hormone is signaled by human growth releasing hormone, etc. Before we talk about each individualized hormone, we have to talk about the mnemonic. So maybe you have an exam in 5 minutes. Let's kind of rush this through. We have the flat peg. We have FLATPEG. We have follicle stimulating hormone, luteinizing hormone, the adrenocorticotropic hormone, so ACTH, We also have thyroid stimulating hormone. We have prolactin, so this is PRL, prolactin. We have the endorphins, so we're just going to call this endorphins, specifically beta endorphins. And then we have human growth hormone, so we're just going to call this GH. Follicle stimulating hormone, luteinizing hormone, and TSH, these are actually called glycoproteins, so we're just going to call this glycoprotein. This is another glycoprotein. This is a glycoprotein. Growth hormone, which is typically injected by bodybuilders, is a protein itself. It's just a protein. So to build muscle, you have to eat lots and lots of protein. So if Arnold just injects growth hormone, human growth hormone, and he doesn't eat protein, he's not going to build all those muscles. Prolactin is when the mother secretes milk for the baby, and so milk is a liquid, and the baby wants lots and lots of liquid, lots of milk, and so we're going to have tides of milk. So we can say that prolactin is a peptide. For adrenocorticotropic hormone, when I think of this, I think of tropic, right? So tropic kind of reminds me of tropical. So tropical, right? So tropical. And he's upset because all around him are all these glycoproteins. And they're like, oh, we're in a group, we're so cool, you're out of the group, go sit somewhere else. And so now he's a little upset. And he says, you know, whatever, let's go on vacation. So instead of having this, I think of adrenocorticotropic hormone as going to the Bahamas, the tropics. So this is the tropics. And you have all these little waves, and these waves have tides. So the tides, you have all these little waves making these tides, and you have TH just kind of lounging around, relaxing. And he's in the tropics. He's a peptide. This is a peptide. But sometimes we have to be careful when we're in the Bahamas, because all around us are all these little whirlpools. And a whirlpool is when the water swirls and swirls around in a little vortex, and it sucks up everything. So adrenocorticotropic hormone has to be careful when he's swimming, because he might be stuck in this vortex. So this vortex rhymes with cortex. And you're going to find adrenocorticotropic hormone being sent into the adrenal cortex. And finally, we have a collection. Right here we have follicle stimulating hormone, luteinizing hormone. These guys right here are called gonadotropins. And they are being secreted by the anterior pituitary gland. And if you need to know this for your exam, the endorphins originate from a protein called pro, meaning before, opiomelanocortico protein. And what this protein does is that it can be split into 3 different things. So pro means before. So if we split this way, if we split the opio, we make endorphins. So we make endorphins. If we split in this way for the melano will make melanocytes, which will allow us to have skin pigment, skin color. And cortico, if we split it this way, cortical, that's going to create the adrenocorticotropic hormone, which will create aldosterone. And so this protein is kind of like the precursor for a lot of things, for a lot of melanocytes, endorphins, aldosterone, etc. We will first begin with human growth hormone. So human growth hormone, which is a protein. And another name for human growth hormone is called somatotropin. It's released from the anterior pituitary gland when the hypothalamus signals for the release of growth hormone releasing hormone. And another name for this is called somatorenin. Now notice that both of these words have somato. That is a root word. And what somato means human. You'll see tropin a lot in the names, like corticotropin releasing hormone. Tropin means effect. So here we have human effect hormone, and crinin, let's say that this means create. So we have human create hormone that releases human effect hormone, somatotropin. So somatocrinin releases somatotropin. And now what happens is that you have somatotropin, human growth hormone, into the blood. What happens here is that the body will easily perform lipolysis. Lipo means fat, lysis means cut. So we will cut to fat cells for energy, and that's going to make the body release fat easily. And it also increases growth. Human growth hormone is going to increase the thickness of the bones by increasing osteoblastic activity. It will increase muscle cell proliferation or muscle cell creation. And the way it does that is that the body will easily intake amino acids. So amino acids are floating in the blood. The muscles will readily absorb the amino acids and use the amino acids to create more muscle. But we also have to acknowledge something. Human growth hormone has a diabetogenic effect in which the liver will release insulin like, it's very similar to insulin, growth factor 1. So IGF is called insulin growth factor 1, and it's released by the liver when human growth hormone is in the system. And what IGF does is that it will decrease human growth hormone. So it says, hey, we have too much human growth hormone. We got to release this insulin-like growth factor from the liver to shut down the effects of human growth hormone. Because if you have too much muscle or you keep taking out too much fat, it's going to be detrimental to the body. And so insulin-like growth factor will stimulate the release of human growth inhibiting hormone. Another name for this is called somatostatin. S-T-A-T-I-N, statin. So human again, and statin. The way I remember this, and it's not really correct, but statin, when I think of statins, I think of cholesterol, like rosuvastatin or atorvastatin. And we give statins to reduce something. So we're giving a statin to reduce the human growth hormone. So that's how I remember it. So human growth inhibiting hormone is released by the hypothalamus when we sense an increase in insulin-like growth factors that is produced by the liver. Before we move on, I just want to explain what a diabetogenic effect is. When we have human growth hormone acting on the liver will increase the amount of glucose in the blood. And the way we do this is that we decrease the amount of glycogen. Glycogen is the way the body stores sugar for a long term. And liver will snip the glycogen into pieces and is going to slowly release the glucose into the blood. So when you connect glucose together, it makes glycogen. The reason why we have more glucose in the blood is because the muscle cells need energy. So when a bodybuilder is lifting heavy weights, it needs to feed the muscle. And so glucose would be readily absorbed by the muscle cells to be used as energy for glycolysis. So this is going to increase glycolysis. And this is when the body uses glucose to create ATP. So this is going to increase ATP. And that's why we have a diabetogenic effect. So with people who inject human growth hormone, when you check their blood sugars, is going to be like 250, maybe 300, because the sugar is concentrated in the blood, since the liver is breaking down the glycogen. When I'm learning about medicine, I like to attach conditions to what I'm learning. So here we have 3 different conditions that arise from human growth hormone. So this one right here is called gigantism. And that's when the body produces too much human growth hormone, also known as somatotropin, when the child is developing. And of course, this is genetic. Here we have Robert Wadlow, and he is about 8 feet 11 inches, and he had too much human growth hormone. Here we have an individual suffering from acromegaly. And this happens later on in life when the person has fully developed. For some reason, the anterior pituitary gland also produces too much human growth hormone. This occurs later in life. And you can see that the face is now elongated, and we have an enlargement of the hands. So we have more formation of bone and muscle within the head and the hands. And here we have human growth hormone deficiency. So this is human growth hormone deficiency, which is genetic. All of them really are genetic. Here we have Tom Thumb, and he was a circus performer for, Barnum, and you can watch his documentary. He actually was very famous. He sold out multiple theaters, and he actually performed for Queen Victoria. He was considered royalty. So yes, here are 3 different conditions for human growth hormone. The next 2 hormones that we will talk about are follicle stimulating hormone and luteinizing hormone. So these 2 are paired together because they are gonadotropins. Gonadotropin. And also they are glycoproteins. So glycoproteins. And what they do is that follicle stimulating hormone will increase the amount of follicles. And I'm not talking about hairs on your face or on your arms. I'm talking about specialized cells within the reproductive system. So for instance, within the ovaries, when follicles are being developed, the eggs are released from the follicles. In males, follicles are found within the testes, and that actually matures the sperm. So we have spermatogenesis. So within women, the follicles are being stimulated by follicle stimulating hormone. It's in the name, and that releases the eggs or the ovum. So we have the ovum being released. Within males, the testicles are stimulated by the follicle stimulating hormone, and that generates sperm. But we have to decrease follicle stimulating hormone. So how do we do that? Because we can't just always have this on. And so within the ovaries and the testes, you have a hormone called inhibin. So this is inhibin. And what inhibin does is that it will inhibit the follicle stimulating hormone. So it's going to decrease follicle stimulating hormone. If you want to go the extra mile, the tissue that secretes inhibin, in men this is called the Sertoli cells. And within women, this is called the granulosa cells. In women, and I can't even believe that I misspelled that. This is in men. Sertoli men, men, granulosa, granny, which is in women, granny, granulosa, Sertoli, yes sir, men. And this is missing an A, so that's an A, granulosa. Now let's clear the board and let's talk about the luteinizing hormone. Now we have luteinizing hormone, and in women, luteinizing hormone will go up and down, up and down. It will be labile, and that dictates the menstrual cycle for women. The levels of luteinizing hormone are the highest when the woman is ovulating, so ovulation. So if a couple are trying to create a baby and they want to be pregnant, well, they would have to time it so that the luteinizing hormone is the most concentrated, like the highest, and that's during the ovulation period. And when the woman has a menstrual cycle, the levels of luteinizing hormone are actually depressed. Within men, the luteinizing hormone stimulates the production of testosterone. Also, you should know that within women, luteinizing hormone stimulates the production of estrogen and progesterone. The next hormone is called prolactin. So we have pro before, and then lactin, which means lactation, milk. And prolactin works very closely with oxytocin, follicle stimulating hormone, luteinizing hormone, estrogen, and actually progesterone. So it's a big, peptide. So again, this is a peptide. Now, what it does is that normally when the woman is pregnant, prolactin levels, PRL, are depressed. But this woman is having labor contractions, and when the labor contractions are happening, the oxytocin level is increasing via a positive feedback loop, and eventually that baby is born. So when that happens, the oxytocin level kind of decreases. But when you deliver the baby, you have to wait on the mother to pass the placenta. The placenta was formed so that the baby can receive nutrients and oxygen and to excrete waste. But that placenta was also producing estrogen and progesterone. So that placenta was increasing estrogen and progesterone. When that placenta exits the woman's body, this level of estrogen and progesterone decrease. When this happens, the level of prolactin, PRL, increases. So you can say that estrogen and progesterone help to decrease the prolactin. However, the major inhibiting hormone for prolactin is actually prolactin inhibiting hormone. And another name for this big word is called dopamine. So dopamine is going to inhibit prolactin. Estrogen and progesterone also inhibit prolactin, but not to a great extent. So now when the baby is suckling at the mother's breast, the baby will suckle on this region, on the nipple, and when the cells compress, they send a signal to the brain, and thus the oxytocin levels increase, and oxytocin will cause the nipple to constrict, and that helps the muscle to squeeze out the milk. It helps the breast to squeeze out the milk. When we squeeze out milk, we are producing that milk, and so therefore the prolactin levels are going to be increasing. So now oxytocin and prolactin are working together, and that is called a synergistic effect. That is the synergistic effect. Now, a fun fact about this is that when prolactin levels are high, the levels of follicle stimulating hormone and luteinizing hormone, they are decreased. And so for some women, not all women, for some women, when they breastfeed their child, they often don't have their menstrual cycles. That's just for a very select few women, though. A lot of women who breastfeed still have their menstrual cycles. But for some women, prolactin is going to decrease the amount of gonadotropin releasing hormone. So gonadotropin releasing hormone is going to release gonadotropins, which is follicle stimulating hormone and luteinizing hormone. Not for all women though. The last hormone that we will talk about from the anterior pituitary gland is called the adrenocorticotropic hormone. And I pre-written it because it takes a long time to write it out. The adrenocorticotropic hormone, also called corticotropin, is released from the gland when the gland receives a signal called adrenocorticotropic releasing hormone. So that's kind of like the starting signal that we have to release ACTH. This is also called ACTH. The beginning of adrenocorticotropic hormone starts with adreno, and adreno sounds like adrenal. So we have adrenal. That must mean that we're going to be acting on the adrenal glands. So sitting above the kidneys are two little triangular glands, and when corticotropin acts on the gland, it will have different effects. So if we're under stress, corticotropin will produce a different substance, or if our blood pressure is too high, corticotropin will produce a different substance for that situation. Here we have the kidney, and on top of the kidney are these little pyramid looking things, and this is called the adrenal gland. Now inside the adrenal gland, if we do a cross section, we're going to have different layers, and these different layers produce different hormones. The first section is what we're going to interact with when we're doing corticotropin. So let's say that we have the corticotropin right here. So we have corticotropin. It will interact with the superficial part of the adrenal gland. So the superficial part is kind of close to the glomerula of the kidney, and so we're going to call this zona glomerulosa. Keep in mind that corticotropin will also interact with the zona fasciculata, but for right now, let's just focus on the zona glomerulosa. So when we have the zona glomerulosa, we are going to be creating mineral corticoids. So these are substances that influence the amount of minerals in our blood or in our urine. So adrenocorticotropin releasing hormone will go from the anterior pituitary gland into the adrenal glands, and when it interacts with the zona glomerulosa, is going to create mineralocorticoids. Specifically, we're going to create aldosterone, and that is a steroid. In fact, the adrenal glands create steroids, except for the adrenal medulla. The adrenal medulla will create the catecholamines such as adrenaline and norepinephrine. But for these sections right here, these are creating your steroids. When the body senses that there is low blood pressure, so we have low blood pressure, or low blood volume, or we have too much potassium in the blood, the body will release corticotropin releasing hormone, which will then release corticotropin hormone. And that corticotropin hormone will act on the zona glomerulosa to create aldosterone. Why do we create aldosterone? Because aldosterone is going to undergo a pathway to increase the blood pressure and to increase the blood volume and to decrease the amount of potassium in the blood and to eventually increase the sodium. So if we have low sodium levels, this is what's going to happen. This is going to be called the renin-angiotensin-aldosterone pathway. And this is actually a very critical pathway in which pharmaceutical companies will lower blood pressure with drugs, and so many things are based upon the RAAS pathway. So this is called the RAAS pathway. So what happens is that when we have aldosterone is going to be produced within the zona glomerulosa, and aldosterone is going to react with an enzyme called renin. So the renin enzyme. Renin sounds like renal, and the renal means kidney. So this enzyme is being produced by the kidneys, and renin is going to interact with aldosterone. What happens is that the renin enzyme will interact with a protein found inside the liver. So in the liver is producing a protein called angiotensin-aldosterone. So gen means to generate, genesis. So eventually when we have renin interacting with angiotensin-aldosterone, we will generate angiotensin 1. So angiotensin is being generated by angiotensin-aldosterone interacting with renin, and we create angiotensin 1. Now, angiotensin 1 is then going to go into the lungs, so we're going to transfer this to the lungs, and angiotensin 1 becomes angiotensin 2. So to recap, corticotropic releasing hormone in the hypothalamus allows for the secretion of corticotropin hormone. Corticotropin hormone will interact within the zona glomerulosa to produce aldosterone, which is a steroid. Aldosterone is going to interact with renin enzymes found inside the kidneys, and renin is going to go into the liver and interact with the angiotensin-aldosterone protein. Angiotensin-aldosterone is then converted by renin into angiotensin 1. Angiotensin 1 will move its way into the lungs, where it will be converted into angiotensin 2. The way that angiotensin 1 converts into angiotensin 2 is via the angiotensin converting enzyme. So you have pharmaceutical companies creating drugs like Benicar. So Benicar is a brand name drug that is olmesartan, metomadoxal, and that is an ACE inhibitor. So now you have ACE inhibitors. And there are antihypertensive medications which prevent the formation of angiotensin converting enzyme. If you don't have that enzyme, you cannot convert between angiotensin 1 into angiotensin 2. If you cannot create angiotensin 2, then you won't have this effect which increases the blood pressure. And so ACE inhibitors will help to decrease the blood pressure. But we have to ask ourselves, how does angiotensin 2 increase the blood pressure? How does angiotensin 2 increase blood pressure? Well, angiotensin 2, we're going to call this ANG2, is going to increase the amount of antidiuretic hormone, also called vasopressin. You're probably wondering, hey, Brian, I thought vasopressin was going to increase the amount of sodium we excrete in the urine. And that is true. But angiotensin 2 will activate these little pumps. And these pumps are not aquaporins. Instead, these pumps are sodium hydrogen pumps. So we have sodium hydrogen pumps. We want to increase blood pressure. So we're going to conserve water with these little aquaporins, but we're also going to conserve sodium. So sodium, let's say that this is sodium, right here, this is sodium. Sodium is going to go back into the tissue with these little sodium hydrogen pumps, and hydrogen is going to go into the urine. So this is hydrogen, and this is going to be sodium. This means that the urine that is excreted due to angiotensin 2 is going to be acidic. So we might have a pH that is maybe 4.5, a little acidic. And we're going to be increasing the amount of sodium inside the tissue. So when we have more solute inside the blood, the water is going to be pushed inside the blood. Therefore, angiotensin 2 is going to increase the blood pressure. It's going to increase the amount of sodium inside the blood. It's going to increase the blood flow, increase the blood volume. But notice that only sodium is being taken inside with these sodium hydrogen pumps. So other minerals such as potassium are going to be excreted. So it will decrease the amount of potassium inside the blood. Also, angiotensin 2 is going to increase the production of aldosterone. And therefore, aldosterone can start the renin-angiotensin-aldosterone system. So the renin-angiotensin-aldosterone system can start over again due to the production of aldosterone that is stimulated by the angiotensin 2. So that was when we have low blood pressure and we need to increase the blood pressure. But notice that corticotropin hormone, also known as adrenocorticotropic hormone, can have a different effect on the body in terms of stress. So this pathway is what happens when we are under stress. When the body enters a long period of stress, we will begin producing stress hormones. So the following pathway is when we need to produce stress hormones. So this is long-term stress. So let's say we have Courage, the cowardly dog, learning about hormones, and he had to read 50 pages of hormones and then condense it into a lecture video so that people can have free education. Well, it's pretty stressful. And now his body is going to send signals. It's going to have adrenocorticotropic hormone, ACTH, acting on the adrenal glands. Now, instead of creating aldosterone, we're going to be creating stress hormones because our blood pressure is fine. So the adrenal gland is going to be the zona fasciculata. So that's the zone under the zona glomerulosa. Now the zona fasciculata is going to produce glucocorticoids. So glucocorticoids. Ooh. The reason why we call these glucocorticoids is because eventually these stress hormones are going to increase the amount of glucose in the body, because this right here is going to increase catabolic processes. So that must mean that we're going to be breaking down glycogen, breaking down lipids, all that to produce energy for the body. Because the body is under stress, it has to feed itself. This may happen when you don't have enough food. Let's say you're stuck in the wilderness. Well, you're going to enter long-term stress, and therefore the body has to start breaking down fats to feed itself. The process is increased with the uses of glucocorticoids. Now, the main glucocorticoids are actually the stress hormones. So we have cortisol, that's the main one. We have cortisone, so cortisone, which is like moderately produced. And then we have corticosterone, which is little. It's just a little bit is produced. So cortisol is the main stress hormone, cortisone is moderately produced, and then corticosterone is barely produced. So when you think of the stress hormone, you could think of cortisol. All three of these guys are steroids. But now let's talk about the general adaptation syndrome. So we have the general adaptation syndrome. And really, there are 3 stages that courage undergoes. The first stage is actually the alarm stage. So this is the alarm. For the alarm stage, let's say that a spooky monster pops out of nowhere and it scares Courage. Well, when this happens, you're going to have him freaking out. So notice that he has bulging eyes, he's gasping for air, he's scared. This man is frightened. So this is the alarm stage. That's when the body sees the threat initially. And so what happens here is that you have the increase of epinephrine, so epinephrine. And you also have the increase of norepinephrine. And what these guys do is that they're going to increase the pupil size. This is called pupil dilation, to increase the amount of light. When we increase the amount of light into the eyes, it allows the eyes to see better, so we can see what's attacking us. Notice that he's gasping for air, so we have air entering his lungs. The bronchial portion of the lungs, the bronchi and the bronchioles, they're going to expand. They will also dilate to increase the amount of oxygen being taken into his system. And then we're going to have some little vasoconstriction. We're going to have vasoconstriction in his legs and hands and within his digestive system. Because really, when we're running away from a bear or a spooky monster, the body is not worried about eating food. It's not worried about having circulation to the hands or the arms. It's worried about getting enough oxygen into the lungs or seeing the danger. So his mouth is going to be dry. He's going to have vasoconstriction within the arms and legs, but he's going to have vasodilation in his lungs and heart, because a heart needs enough blood to pump oxygen into the body. And again, epinephrine and norepinephrine are produced within the adrenal medulla. And these guys right here are called catecholamines. Catecholamine. So therefore, they are amine-based. And they also undergo the cyclical AMP pathway. In the second stage, we have resistance. So first we have the alarm stage, and now we have the resistance stage. And here we have courage, and he was shooting up with, let's say, somatotropin. So somatotropin. Can you guess what that is? Human growth hormone. So let's say that courage wants to resist the monster, and he shoots up with human growth hormone, and he starts making a lot of muscle. So now he's going to be resisting that stimuli. And it's important to note that in the alarm stage, when we had adrenaline and epinephrine and noradrenaline, that was actually via the sympathomedullary pathway. So that's when he was creating adrenaline and noradrenaline via the alarm stage. So this is actually called SAM. But eventually, everything has to come to an end. Eventually, let's say that this monster is really persistent and his body just starts breaking down. So now we go back into stage 3. Stage 3 is called the stage of exhaustion. So that's when he is constantly stressed and his body starts giving up. His body starts doing catabolism. So that's when we start breaking fat for food. We start breaking muscles for food. We start using glucose or glycogen for food, for energy. And there's a lot of stress in the body. When this happens, our cortisol levels are skyrocketing. And this can have disastrous effects on the body. You can have a heart attack. You can have the shakes. You're constantly shaking and nervous and you're sweating. And that is no way to live. And unfortunately for Courage, he's always at the point of exhaustion. So it's very sad for him. So that can be fatal. In the zone under the fasciculata, we will be producing the androgen. Specifically, we're going to be producing dehydroestradiol, testosterone. So dehydroandrosterone is going to be producing the androgens and sex hormones, so it helps in creating testosterone. So you can think of this as like a masculizing hormone, and that's really all there is. So dehydroandrosterone, we're just going to call that DHEA. And levels of DHEA peak at around 25, and throughout your life they will continuously decrease as you age. And finally, we have the adrenal medulla. So the adrenal medulla is going to be producing catecholamines. So this is the catecholamines. And again, you're going to have your epinephrine right here. And also your norepinephrine. And as the name implies, these catecholamines are amines, and they are derived from tyrosine. The epinephrine and norepinephrine are secreted from the medullary pathway via the sympathomedullary pathway, also known as SAM. And the effects on the body is that it's going to increase the blood pressure, it's going to increase the vasodilation within the heart, so the arteries in the heart, the lungs, so like the bronchi and the bronchioles are going to widen up to allow more oxygen to go into the lungs, and it helps us breathe. And then we're going to have vasoconstriction. And that's pretty much in the stomach and the arms and the legs. You don't need that much blood circulation, just enough to have oxygen into the body part, but not enough to take away from the heart and lungs. So for instance, I wouldn't be hungry if a bear is chasing me. I wouldn't want to allocate energy in producing saliva in my mouth when I'm running. So my mouth is going to be dry and my stomach is not going to be hungry. Also, we have pupil dilation. And that allows the person, which is me, to see the attacker. It could be a bear or a monster. And the way that the kidneys secrete it, or exactly the adrenal medulla, is that within the adrenal medulla we have cells called chromaffin. So we have chromaffin cells. And these guys secrete epinephrine and norepinephrine. So adrenaline and noradrenaline. Before we move on and talk about other organs and other hormones, we have to realize that there is an area between the anterior pituitary gland and the posterior pituitary gland, and this is called the intermediate gland, or I guess the intermediate area. So we have the intermediate gland. And what this does is that it secretes melanocytes. So it secretes melanocytes. And what melanocytes do is that they will show the color of the skin. So this is melanin, and that allows people to have different shades of color. So for instance, me being Hispanic, I'm a little bit darker than a Caucasian person. However, everybody typically has the same amount of melanin capacity. So a Caucasian person and I have the same amount of melanin in our body. However, how much we show of that melanin is dictated by DNA. So DNA. So for a Caucasian person, the DNA codes for a little bit of melanin, even though we have the same amount of melanocytes. My DNA codes for more expression of melanin, even though that person and I have the same amount of melanocytes. The way that melanocytes are derived come from the pro-opio-melanocortin protein. And again, opio means endorphins. Melano means melanocytes. And cortin means that we can create corticotropin hormone or adrenocorticotropic hormone. And the way that we split this guy up is that we're going to be using something called the melano stimulating hormone. And so once this guy is cut up, we're going to be using the melano-stimulating hormone to grab this melano piece and to form the melanocytes. And now we finally get to talk about something other than the pituitary gland. Here we have the pineal gland. So the role of the pineal gland is to secrete melatonin. So melatonin. And that allows us to sleep. So it controls the circadian rhythm. This is the gland that allows you to sleep at night. And the way it does it is that it uses the eyes, not pictured here, to send signals into the pineal gland. At nighttime, there is less light. So we have less light. That must mean that we have more signals from the eyes into the pineal gland. And what is creating these signals? Well, it's actually the suprachiasmatic nucleus. So that is the suprachiasmatic nucleus. Suprachiasmatic nucleus. So the suprachiasmatic nucleus will send signals to the pineal gland at night, and the pineal gland will then activate the pinealocyte cells. So we have the pinealocyte cells, and these guys secrete melatonin, which allows us to sleep. So we have sleepy time. So that's actually an artist that I saw in Dallas in March, Zahara. They're really cool. If you haven't checked out their music, they're really nice. Personally, I like Get Out of LA and Spam Masubi Cigarette. It's really good. And so in the morning, the reasons why we don't feel sleepy in the daytime is that the light is more in the morning. You get it? And because we have more light, we will decrease the amount of signals that the suprachiasmatic nucleus produces. And that's why we don't really feel sleepy in the morning. And finally, melatonin is actually an amine hormone. Melatonin is a mean person when you wake them up. So don't wake up melatonin because they are a mean person. We will now be talking about the thyroid and the hormones that it produces. We're going to be going over how T3, so we have T3 and T4. How are they formed? Well, to first begin this process, we need another hormone. We need the thyroid stimulating hormone, also known as thyrotropin, which is itself a glycoprotein. When thyroid stimulating hormone acts upon the thyroid, the little follicle cells, which are kind of like jail cells, as you'll soon see, it allows these follicle cells to intake iodide. So iodide. And from now on, we're going to be calling iodide just I negative. So the combination of iodide and thyroid stimulating hormone within the follicle cells, so we're going to have a collection of iodide, is going to cause the thyroid to accumulate iodide. So again, we have thyrotropin activating the thyroid. This allows the follicle cells to suck up the iodide from the blood, and we have this large accumulation of iodide in the follicle cells. And notice that they're kind of accumulating around this little white pool. And this little white pool is called colloid. Colloid. And colloid is kind of a thin, clear substance that is sticky. And it's very important in the formation of T3 and T4. When you have a large amount of iodide ions concentrating around the border of the colloid, they undergo oxidation. And so the iodide portion will become oxidized, so we're going to go oxidation, to remove this negative electron. So now we just have I, which is just iodine. If you do this twice, you will end up with iodine. So this right here is iodine. And that's just a combination of two iodide ions that have gone oxidation at the border of the colloid. And now iodine will enter the colloid. So let's clear our board. Iodine, which is I2, have formed around the border because they just became oxidized. And now we will enter the colloid. So now we have iodine inside the colloid. Now inside the colloid, we have a very important enzyme. We actually have the perioxidase enzyme. So the perioxidase enzyme lives inside the little colloid area. So it's just hanging out in the pool, chilling, doing its thing, you know. And it takes in the iodine and then it pairs it with a tyrosine. So the peroxidase enzyme pairs these guys with a tyrosine. When we pair iodine and tyrosine together, we can have two different products. So tyrosine will have one iodine attached to it, or tyrosine can have two iodines attached to it. Right there. Now, this is not in the book, it's not in lecture, but to save time on drawing this, this will be called Ti1, and this will be called Ti2, because it's tyrosine with two iodines attached to it, and this is tyrosine with one iodine attached to it. Right here, let's actually remove this picture. This is just the anatomy of the thyroid. You can have two different combinations. You can have Ti1 combining with Ti2 to give you T3. So that's tyrosine combined with 3 iodine. And this is actually triiodothyronine. And it's the most powerful thyroid hormone compared to T4. So it will have more effects on the metabolism. Now the second combination, you can combine Ti2 plus a Ti2 to give you T4. Or you can call this tetra, meaning 4, iodothyronine. This is actually more common. So this is more common. And it's so common that we have another name for this, and this is called thyroxine. So it's really common and it rocks. That's why we call it thyroxine, because it rocks. Meaning it's really cool and good. but you have to realize that T4 is readily converted into T3. The way that we release the T3 and T4 hormones, so the triiodothyronine and the thyroxine, is that now we have the T3, we have T4, and the colloid, thyroid stimulating hormone, is going to push these guys into the follicles. So we're going to push these guys back into the follicles. So now we have T3 and T4 all over the follicles right here. So just imagine they're inside these little purple dots. And now we have another enzyme called lysosome. So lysosomes will cut, these are going to cut the follicles open. And when this happens, the T3 and T4 explode all over the place. So now we have T3 all over the circulatory system. However, you don't just want random T3s and T4s all over the circulatory system, because if you have just a high amount of T3 and T4 in your blood, they're going to be reacting with tissue, and that's going to increase your metabolism, and sometimes your body doesn't want that. So we have to regulate it. We have to limit how much T3 and T4 are in the blood. And so we have these little taxis. We have these little taxis because the T3 and T4 will go into the taxis and ride into cell tissue and hide until they're ready to come out. So we call this the thyroxine binding globulins. So you can kind of imagine a goblin as a taxi driver. You know, he turns around from the driver's chair or driver's seat, and his passengers are the T3 and T4s. So the thyroxine binding globulins or goblins are going to take the T3 and T4. So they're both going to be here, and they're going to go somewhere else. Specifically, they're going to go into plasma proteins. So plasma proteins, such as albumin. That's a big one. That's a big protein in the blood. So albumin. So now T3 and T4 are in this albumin until they're ready to be released. And about 99% of T3 and T4 are bound within these proteins in the blood. Only 1% of T3 and T4 are active at any given time. The reason why we use T3 and T4, so we have triiodothyronine and thyroxine, so tetraiodothyronine. The reason why we use them is because they increase metabolism. They increase metabolism. They also allow for the creation of proteins and the creation of proper fetal development. They increase body heat, so thermogenesis. And the mitochondria can use T3 and a little bit of T4, but mainly T3 because T4 converts into T3 for the most part. The mitochondria can use T3 to increase ATP production, and it also increases oxygen consumption because this will allow us to do glucose oxidation, which is actually pretty inefficient. It doesn't generate as much ATP, but it does generate heat. And finally, T3 and T4, so triiodothyronine and thyroxine, will actually increase the sensitivity to catecholamines, which again are epinephrine and norepinephrine. So what this does is that it allows the blood vessels to suck up the epinephrine and norepinephrine pretty easily. So now it's going to readily accept the epinephrine from the adrenal medulla. Here we have the negative feedback loop of the T3 and T4 hormones. So the body senses if the T3 or T4 is low or high. If it's low, again, we're going to have the hypothalamus releasing the thyroid releasing hormone, and that triggers the anterior pituitary gland to release thyroid stimulating hormone. From then on, the thyroid stimulating hormones are going to activate the process of creating T3 and T4. So you have the iodide atoms or accumulating within the border of the colloid, so within the follicles, and they are oxidized and subsequently become T3 and T4 through that process. And now the mitochondria can use T3 and T4 to increase ATP production, heat production, energy production, oxygen consumption. But we have to limit how much T3 and T4 we have. And so elevated levels of T3 and T4 are going to stop the release of thyroid releasing hormone and thyroid stimulating hormone. So therefore the hypothalamus stops the thyroid releasing hormone, and the anterior pituitary gland stops the production of thyroid stimulating hormone. Therefore it is a negative feedback loop. Here we have 3 different conditions that arise from the imbalance of thyroid hormone. So the first one, we will notice, this is called Graves' disease. Graves' disease. And you often see this with hyperthyroidism. Now notice that with this individual, the eyeballs are protruding out of the socket almost entirely. And this is called exophthalmos. So individuals with Graves' disease, they're going to have an increased amount of T3 and T4. So that must mean that they must feel hot. So they feel hot. They're often underweight. And sometimes, if you look at their hands, they have tremors. And the metabolism is increased. So the metabolism is increased. With individuals with hypothyroidism, so we have hypothyroidism. So that would be this individual and this individual right there. They are producing too little T3 and T4. Here we have a goiter, and the reason why the goiter forms is because the thyroid is increasing in size. Why do we do this? Well, the thyroid is trying to grow stronger, quote unquote stronger, so that it can suck up the little amount of iodine that is in the body. So if the goiter is large enough, maybe it can compensate for the low amount of iodine in it. But often it fails, and now you have an enlarged thyroid. And this is actually one of the most preventable conditions in the world. It stems from a person not getting enough iodine in their diet. And so when you look at a salt, like go in your kitchen and you'll see that the salt says iodized. Well, that allows at least the Western diet to have enough iodine in the diet to prevent goiters. Here we have the fetal hypothyroidism. And children that are born with fetal hypothyroidism, you will notice a swollen tongue and an enlarged abdomen, and it's very difficult for them to breathe. So when you're evaluating a pediatric patient that has fetal hypothyroidism, they will breathe like this because it's very difficult for them to breathe. This child will also be very sleepy, fatigued, and lethargic. They're not going to be eating as much as the other children. And during their development, it will take longer for them to perhaps speak or reach milestones that are otherwise typical for other children, such as walking or developing into a toddler. So it just takes them longer to do that. And often enough, these children who are dealing with fetal hypothyroidism, well, they usually have an umbilical hernia. So that's when the intestine has kind of escaped the abdomen muscle and it's sitting on top of the stomach. So it's still under the skin, but there's a little lump that you can feel, and that's actually the intestine. Going back into the hormones for the thyroid, you also have another one called the calcitonin hormone. So this is calcitonin. And it's excreted by the thyroid, but it's not really that powerful. Now, calcitonin is actually a peptide hormone. So this is a peptide hormone. And it's released when we have what? When we have too much calcium. So too much. And another way you can think about it is that we are toning down the calcium. We are toning down calcium. We do this by decreasing the osteoclastic activity, so the osteoclasts activity decrease, because osteoclasts are cells that slowly break down the bone and release calcium into the bloodstream. We also decrease vitamin D synthesis. We decrease that because vitamin D allows the small intestine to absorb calcium more efficiently in the diet. We also increase calcium excretion from urine. And finally, we increase the osteoblastic activity. So these are the little cells in the body that will take calcium and push it into the bone when they create more bone tissue. When people have thyroidectomies, that's when you surgically remove the thyroid. For instance, one of my friends had thyroid cancer and she had her thyroid removed. She's doing well. But when you remove the thyroid, you also remove the body's ability to produce calcitonin. And they did studies and years apart where the calcium levels were marginally affected. So calcitonin is not really that powerful, and the body has other ways to regulate the calcium levels. So we don't really heavily rely on calcitonin to regulate calcium levels. Here we have the posterior view of the thyroid hormone. So that's when we take the thyroid and we look behind it, and we notice that there are some little lima bean looking things right here. These guys are the chief cells. So this is actually the chief cells. And what the chief cells do is that they produce and secrete parathyroid hormone. And the reason why we produce parathyroid hormone is because sometimes the calcium levels are depressed. And so we release parathyroid hormones so that we can increase the amount of calcium in the body. How do we do that? Well, we're going to be doing the exact opposite of calcitonin. In that case, we're going to decrease the amount of calcium excretion in the urine. So we're going to be retaining calcium. We do not want to urinate the calcium. We will also increase the osteoclastic activity. So these cells are, again, they're going to go into the bone and start releasing calcium from the bone and release the calcium into the blood. We will also increase the synthesis of vitamin D, because again, vitamin D allows the person to absorb calcium from the diet more readily, more efficiently. And we also decrease osteoblastic activity. And finally, we also increase magnesium absorption. And again, PTH is actually a peptide. That is a peptide hormone. Here we have the pancreas. This is the pancreas right here. And the pancreas secretes 4 different types of hormones. The pancreas also has 4 different types of cells. First, we have the alpha cell. So this is the alpha cell, and that's going to release glucagon. So when our blood sugar is too low, the pancreas will secrete glucagon from the alpha cells, and it will increase the glucose levels. So that will increase glucose. If the blood sugar is too high, we will secrete the beta cells. So the beta cells are actually going to secrete insulin, and that will help to decrease glucose. So let's say you ate 16 pies and 16 cakes. Well, the pancreas is going to release insulin so that the body can take in that glucose and convert it into fat, and also use some of the glucose for energy. We also have the delta cells. So delta cells will actually release somatostatin. And you're probably wondering, hey, isn't that human growth inhibiting hormone? And you know what? It is. But instead of inhibiting the growth of the human body, it actually inhibits the secretion of alpha cells and beta cells. So it's going to decrease the amount of glucagon and decrease the amount of insulin in the body. And then finally, we will also have the polypeptide. So we have polypeptide hormone. Or I guess you can say polypeptide proteins. Let's just call that polypeptide proteins. And what this does is that it will increase the production of gastric acid. And it will decrease the production of bicarbonate. So that allows the stomach to really produce acid, and it decreases the base in the stomach. So let's say you eat a hamburger. The pancreas will release these polypeptide proteins, and it will go into the stomach and increase the amount of hydrochloric acid to aid in digestion. Now, if you want to be a brainiac, there's about 20% of cells in the pancreas that are alpha cells. There are 75% that are beta cells. The rest are going to be 4% delta cells, so 4% delta cells, and only 1% of the polypeptide proteins. So the pancreas does have digestive enzymes, but it's not really that significant. We have other ways of increasing the stomach acid for the digestion of food. So 20% of the hormonal cells in the pancreas are alpha, 75% are beta, which release insulin, 4% are delta cells, which inhibit the secretion of glucagon and insulin, and only 1% are polypeptide proteins. Insulin and glucagon follow the classic negative feedback loop. Here we have the starting point. Let's say it's 90 milligrams per deciliter of glucose within the blood. If we have too much blood sugar, we have hyperglycemia. And so the pancreas will stimulate the release of insulin from the beta cells. And what insulin does is that it will make the cells suck up the glucose from the blood and convert some of the glucose into what? Into fat. And it also prevents the liver from creating glycogenolysis. So glycogenolysis, again, here we have glyco, that means sugar, genolysis. And that means that we are going to be cutting the glycogen. When we cut glycogen, we increase glucose. So instead, we want insulin to prevent this from happening. We want to decrease the amount of glucose in the body. So we prevent glycogenolysis. We also prevent the formation of glycogen and glucose. When we prevent glucose from forming, such as from fat, let's say, this is called gluconeogenesis. So we decrease gluco, that means sugar, gluconeogenesis, and we know that genesis means creation. So it decreases gluconeogenesis. So sometimes when the body is starving, it will convert fat into glucose and use that for energy, because glucose is pretty much easy to process. Insulin will prevent that from happening. Now let's go back to this area right here. If we start at 90 and somehow we have a decrease in blood sugar, we have hypoglycemia, and that must mean that the body is not producing enough sugar. Therefore, we're going to stimulate the alpha cells in the pancreas. And when we stimulate the alpha cells in the pancreas, we're going to be increasing the amount of glucose in the blood. So this right here means that we will decrease the usage of glucose. We're going to increase glycogenolysis. It will increase gluconeogenesis. Neogenesis. And so we can say that insulin itself is actually anabolic, because we want to create something. We want to create glycogen. We want to create energy storage. So we take this glucose and we convert it into a form of energy storage. We create more glycogen, which is just glucose connected to each other. Likewise, we can say that glucagon is actually catabolic. It will start cutting down glycogen or cutting down fat to create into glucose. So this is catabolic, while insulin is actually anabolic. And I should have said that insulin, glucagon, somatostatin, those little delta cells, are all peptide hormones. So these are all peptides. And alpha cells, beta cells, delta cells, and polypeptide proteins are located in the islets of Langerhans within the pancreas. Within the body, some tissues can also secrete hormones. For instance, we don't often think of the heart as secreting hormones, but it does. Because when the blood pressure is increased, the amount of pressure within the atria increases. So the cells within the atrial walls stretch, and when they stretch, they send a signal to release atrial natriuretic peptide. So this is atrial natriuretic peptide, and what it does is that it will help to decrease the blood pressure and also decrease the blood volume. And the way it does this is that it increases sodium secretion, and therefore it increases water excretion. So we will start urinating more. So urinates more. And also it inhibits, or it decreases, that's a better word, we can say it decreases the renin-angiotensin-aldosterone system. So again, that's a major pathway that ultimately will increase the blood pressure. So the atrial natriuretic peptide will decrease blood pressure and decrease blood volume by increasing the amount of sodium we urinate out, and increase the amount of water we urinate out, and it also decreases the renin-angiotensin-aldosterone system. And the way it disrupts the RAAS pathway is that it decreases the amount of renin that is produced in the kidneys. So it decreases renin production in kidneys. Within the digestive system, the GI tract has several hormones that it can secrete. One of them is called ghrelin, and ghrelin increases the amount of hunger in a person. We also have the gastrin, and that's the main hormone found within the stomach that increases the secretion of hydrochloric acid. And by the way, all these hormones that I'm talking about in the GI system, these are peptides. So those are peptides. You also have secretin. So secretin, that is produced by the small intestines. So the small intestines secrete secretin, and that is their little secret. Haha, their little secret. And what does secretin do? Well, it increases bicarbonate production. Why would you want to do that? Well, when the food moves, you have this little mound of food, and this food has acid. And you don't want this food that is very acidic to enter this very soft lining. So instead, we're going to neutralize it with a base so that this acidic food doesn't hurt the lining of the small intestine. And by the way, food that is acidic and is exiting the stomach, that is called chyme. So that is called chyme. That is acidic food. Another hormone that we secrete is called, I have to look at it, how it's spelled, so that's C-Y-S-T-O-kinin. Cholecystokinin. What is cholecystokinin? Well, cholecystokinin increases the amount of pancreatic enzymes. So it increases the pancreatic enzyme concentration within the GI system. And it also stimulates the increased production and release of bile from the liver, which actually helps us digest fat. Go figure. And now I know that this isn't really part of the digestive system, but it does deal with hunger and food. So all around us, let's just say that there's fat right here. So there's fat here, and there's fat here, and there's fat here and here. Well, these fatty tissue called adipose tissue are going to secrete another peptide hormone, and they secrete leptin. Leptin increases after you've had a meal, and that makes you feel full or satiated. So after eating 10 pounds of barbecue, you're like, oh, I don't want to eat anymore, I'm full. That's because the adipose tissue in your body is releasing leptin. However, the more adipose tissue that we have covering the organs, the less leptin we have. So the more adipose tissue we have, the less leptin we produce. And that's why individuals who have a large deposit of adipose tissue in their body, well, they often feel like they're still hungry. And that's because they don't have the same amount of production of leptin in their body as opposed to a skinnier person. The kidneys, right here, the kidneys can actually produce a hormone called erythropoietin, or EPO. Now what erythropoietin does naturally is that it will increase the amount of red blood cells, and therefore it will increase the body's ability to deliver oxygen into the muscles. So the mitochondria can intake oxygen and supply energy to the muscles. Now some athletes, this is Lance Armstrong, and he was known for winning the Tour de France tour for bicycling or cycling numerous amount of times, and he actually won the Tour de France many times. However, it was found that he was blood doping. So he was doing blood doping. And the reason why he was blood doping was because before, some people were injecting EPO into their system, but EPO can be found in certain blood tests. Blood doping is a little harder to spot, but they caught him. When you blood dope, the blood is taken out of the athlete's own body and it's centrifuged, it's spun around really quickly. 5 weeks before the games, the blood is taken out, and about 2 or 3 days before the event starts, the red blood cells are re-injected into the body. So the body has re-injection. We have the injection of red blood cells. So the body already went back to normal, to the normal amount of red blood cells. Now you're adding more red blood cells into the body. So Lance Armstrong took about 5 weeks to regenerate his red blood cells that were taken out, and then maybe 2 days before the event, he injected those red blood cells that he took out. And when he injects those red blood cells, he increases his body's ability to take in oxygen and supply his muscles with energy. And so that gave him the unfair advantage that he needed to win the Tour de France. And so he was stripped from his medals, and people took away their partnerships, and he was ostracized for cheating. One of the ways that the body inhibits the overformation of bones is through the usage of fibroblast growth factor 23. So FGF23 is used when the amount of phosphorus increases, and also when we have too much vitamin D. So when the body senses that we have too much vitamin D or phosphorus, it will increase the amount of fibroblast growth factor 23 hormones. And one thing that we have to know is that this guy right here will help us excrete phosphorus and also decrease calcitriol. So that is the hormone that vitamin D converts into, calcitriol. You can also consider this as hormonal vitamin D. And overall, this decreases bone formation. And before I forget, because I forgot the entire video, it's been like more than 2 hours recording this, alcohol, which is ETOH, ethyl alcohol, will decrease antidiuretic hormone. So that's why when you have like 4 shots of vodka, in about 30 minutes you're urinating a lot, because again, the body is excreting a large amount of urine because we don't have enough production of antidiuretic hormone. That is because alcohol is an inhibitor of antidiuretic hormone, also called vasopressin. And vasopressin is a peptide hormone produced by the posterior pituitary gland. And that is all we have for this lecture. So I hope that you learned a lot, because I sure did. And it's been more than 4 hours recording and editing, and this has been fun. So again, thank you so much for watching. I love you so much, and just know that you are awesome and loved. So how do you eat an elephant? You take one bite at a time. And I'm very glad that I've been a part of your education. Well, I love you, and take care. Bye-bye.